Hi everyone. Sorry for the delay. I am going to speak a little bit about the dental stream. I'm Dr. Ruppel, VP of Mentoring. Any questions, please do post them. If I don't have an opportunity to answer them now, I'll answer them afterwards. Just for you medics who are waiting to see the medical stream, Dr. Quinn is unfortunately unable to make it tonight, so she said she will be with you at 7 o'clock tomorrow night. So make sure you log on. She'll go through the PBL case and the rest of the study guide as well. So the situational judgment tests and the current affairs scenarios. So please do log on tomorrow night. Apologise once again. Busy life of a doctor, you see. Okay, so what I'm going to do is I'm going to go through the dentistry specific questions. A lot of these were based around pregnancy. So as we know, pregnancy is a very critical time in both the mother and the child's life. You have to be extremely careful from both a medical and a dental point of view when you're treating these patients. And as you know, gestation period is looking at about 9 months, and that's split up into first, second, and third trimester. In terms of dentistry, it doesn't tend to be a massive difference between the trimesters and when you can treat these patients, but there are certain rules that you need to follow and certain things that you should try to avoid. So if we look at the first question, so why is there an increased risk of developing periodontal disease during pregnancy? So as many of you may know, periodontal disease is a disease that affects the gums and the surrounding structure of the teeth. It doesn't affect the teeth itself. So it affects the gingiva, the gums, the periodontal ligament, which are the ligaments that hold the gums to the bone, the teeth to the gums and the bone. And also when periodontal disease gets to its worst, it can affect the bone as well, and that's why you start to get mobility of the teeth. So why there's an increased risk during pregnancy is, one, there seems to be there are other priorities in pregnancy. So what can tend to happen is patients don't tend to focus so much on their oral health as much, obviously, because there's a multitude of things going on when you're pregnant. There's also an increased risk of decay, which is obviously going away from the question a bit here, but there's increased risk of decay because in pregnancy there seems to be an increased amount of sugar intake. You're also obviously getting some patients may get quite a bit of sickness, so that can obviously start to affect the enamel, not so much from a decay point of view, but more from an erosion point of view. And because you get this decreased kind of importance in oral hygiene, you can have an increase of periodontal disease for that reason. There is also a more biological reason because of the changes in hormone levels in the bloodstream, progesterone and estrogen, that seems to predispose to periodontal disease. So it won't be uncommon that you will get a pregnant lady coming in and saying that her gums are now bleeding more often, or she may have noted that her teeth are mobile, or in extreme circumstances, if the individual has already had periodontal disease and the pregnancy has essentially made it worse, you may get really bad mobility or even drifting of the teeth. So it's mainly to do with the change in hormone levels in the blood during that time. If we move on to the next question, what is a gingival epilus and why is it more prominent during pregnancy? So epilus, it basically just means a swelling of the gum. Epilus only occur in the gum, and it's once again a consequence of the difference in hormones. There are 3 different types of gingival epilus. The most common one in pregnancy is an inflammatory one, and they tend to be really red, really angry, are made worse specifically with poor oral hygiene. So it's kind of like a vicious cycle. If a patient gets an epilus, which you can imagine can occur in between the teeth, okay, kind of sits there in between the teeth, if they're not able to clean between there and they get increased plaque and calculus and food debris that packs there, it actually makes the epilus worse. and then you get this vicious cycle of it just getting bigger and bigger. The way to combat it is to ensure that the patient has really, really good oral hygiene, particularly flossing, because brushing will find it difficult to get under the epilus, whereas floss will get right in between the teeth. And they will also need a degree of scaling as well, so scaling underneath the gum, just with caution, because these epilus, because they're inflammatory, they have a really high blood supply, so they do have a tendency to bleed quite a lot. So you just have to be careful with that. You just have to warn these patients that most of these things, the periodontal disease, epilus is gestational, so it should go once the baby has been delivered. The epilus will, periodontal disease not so much. So it's really, really, really important with both of these things. Oral hygiene is the cure, essentially. If you can get their oral hygiene to a good standard, then they shouldn't suffer with any of these problems. On to the next question. So in what trimester should you avoid the use of local anesthetic? So in pregnancy, like I said, you should try to really avoid any treatment if possible. Okay. Now, obviously, a lot of patients will come to you because dental treatment is free during their pregnancy and also for a year afterwards. So they will come to try and take advantage of, obviously, that free NHS dental care. Because of there's very little research to show that the type of local anesthetic that we use, which is an amide linked local anesthetic called lidocaine, there's very little evidence to show that it has any negative effect on the mother or the fetus. But if you can imagine, it is a medication, and no matter where you're injecting it, it will get into the bloodstream, so it will affect both mother and baby. The key point is local, but it does still can have a systemic effect as well. So you just need to be careful, and specifically need to avoid the first trimester of pregnancy if possible. Now, there are certain circumstances if a patient is in acute pain or infection where you cannot avoid this, because leaving them with that infection would have a more detrimental effect to the mother and baby. But if it's just routine fillings, things like that, scaling, then I would try to avoid it as much as possible. That then leads on to the next question about radiographs and why these should be avoided in pregnancy. As we know, all radiographs and any kind of exposure to radiation is a risk. Now, as dentists and as anybody who is prescribing or operating any kind of X-ray machinery, you need to justify any exposure to any patient. Okay, and once again, in this circumstance, you justifying that unless the patient is in any kind of acute infection or pain is very, very difficult. Okay, you've got a fetus which is developing, and cells are developing at an extremely quick rate, and any kind of radiation could affect that essentially. If you can imagine, your X-ray beam is pointing this way, and obviously not towards the tummy where the fetus will be, but there's still a risk, and obviously there's not much research around that, with the ethical implications, of course, that would involve. So I would try to avoid any form of X-rays in a pregnant individual. Doesn't matter what trimester they're in, unless they're in any sort of acute pain or infection, where you always have to think about your duty of care. In the past, there used to be a rule that pregnant patients could wear a lead apron, but they've now been kind of discontinued, for want of a better word, because what research have potentially found is that the lead, if you can imagine, if I'm wearing a lead apron now and I was pregnant and the X-ray beam gets in, you will get a degree of scatter radiation, and if the scatter radiation ultimately got underneath the lead that was in the apron, it could actually reflect the X-ray beams back towards the fetus. So they've been discontinued now, and we only use X-rays for individuals where the kind of net benefit would outweigh the cost to the mother and baby. So this next question, what is the best remedy for teething, is actually a bit of a trick question, to be honest. If any of you have got younger brothers or sisters or nieces and nephews, teething is a really, really difficult stage for a lot of children. Some will find it completely fine, but the majority of them will really struggle. Things like cool teething rings can help initially when the first teeth come through. It tends to be that children suffer the most with the posterior teeth, and they will come through at an age of around kind of 18 months to 3 years, depending on the child. So it's not uncommon for a child to get an associated viral illness when they have when their back teeth are coming through. Things that we can use, like I said, the cold teething rings, the Bonjela gels can help. One the kind of indications you'll get from a child who's teething, they will have very, very rosy cheeks. They also have a tendency to want to hold or pull their ears, which is quite a common thing. Excessive salivation is another thing. And obviously, if you look in the mouth, you should see some evidence of teeth erupting. But I was a bit mean with that question, actually, in terms of there's not really a best remedy for teething. It's just kind of grin and bear and kind of seeing it through. Soft foods can also help, because obviously there's not as much pressure placed on the teeth as they're coming through. So which class of antibiotics are known to cause defects in children's teeth during development? So these are tetracyclines. Now, the most you'll get kind of oxytetracycline, there's tetracycline, and doxycycline. Doxycycline is probably, we wouldn't necessarily use a lot of them, so dentists don't tend to prescribe a lot of them, especially not in children. Tetracyclines and doxycyclines, the only times I can think that they are prescribed to dental patients is with periodontal disease problems, so gum disease, and that's only in very specialist circumstances. There may be some pediatricians out there who will prescribe these to patients. Oxytetracycline seems to be quite a common one. I found in the past that children have been put on it long term for acne issues. I don't know what age that starts from, and I think that pediatricians are actually quite acutely aware of how these affect the teeth. But you may still get adults now that are coming through with issues, and what it tends to be is it affects the teeth in a very chronological way. So what you'll get is you get a perfectly formed tooth, and then all of a sudden you'll get this kind of brown banding across, and then the rest of the tooth will be perfectly formed, which shows that that patient has been taking that antibiotic at that certain time, and as that tooth has been developing, the tooth bud, it has affected it. They're really, really difficult to deal with, because it's not an extrinsic staining. It's not something you can buff away. It's an intrinsic, and it's actually within the enamel formation. So it's something that you need to be acutely aware of, and something that you could come across in future patients as a possible issue. I've never seen it personally, but I know I have colleagues who have. And like I said, management is quite difficult. Yeah. So using a chart on dental eruption dates, work out which teeth a child of these ages would have. Okay, so hopefully you've been able to easily find a chart of eruption dates. They're quite easy if you just Google it. So at 10 years old, you've got to remember these are kind of averages of what we'd expect. Every child is different. You could get children as young as 3 months getting their first tooth, or as not getting their first tooth till they're 12, 15 months old. So, I mean, this isn't the norm. It's just averages. Everyone is different, so you have to take it with a bit of a pinch of salt. But at about 10 years old, I would expect a child to be in what we call the mixed dentition stage. Okay, so this is the stage in between kind of losing their primary teeth, their deciduous teeth, and moving towards having their adult teeth. So we would be looking really for them to have their so their central incisors, the lateral incisors on the top and the bottom. I would then be expecting them to maybe have their first molars on the top and the bottom as well. Sorry, no, they'll definitely have their first molars, sorry, because they come in at age 6. But I would expect them to maybe have their first premolars as well. Some children may also have their second molars at the very back. Okay, so this is a very kind of dubious stage, because some children are, like I said, a lot faster and may have, even at this stage, have lost all of their primary teeth and have all of their adult teeth. Others will still be very much in this mixed dentition stage, where it's an area where you have to be very aware, and sometimes it's actually quite difficult to pinpoint what is a deciduous tooth and what is an adult tooth. At 6 years old, I would expect them to have their probably just about losing their lower central incisors, so their baby teeth, and their adult teeth coming through. And at 6, I would be expecting their first molars to be erupting. Now, I'll point out to you that obviously parents are always very, very aware when their front teeth are coming through, but they're usually not that aware when their back teeth are coming through. So you will get patients coming through the door that are just like, oh, I didn't realise he had his back teeth through at 6 years. Yeah, they will, and they're really, really important, because they need to start to protect them really early on. I today had an 8-year-old boy in who had issues with his first molar teeth. He's only had them for less than 2 years, and they're all completely broken down. He's going to have all 4 taken out. So it's really, really important that you make patients, parents aware, specifically because they need to make sure they get their brush far back enough to clean these teeth properly. So yeah, a child at 6 years of age would mainly have most of their primary teeth, with the addition of maybe their lower anterior incisors and definitely their 4 molars, okay, in each quadrant. And a 16-year-old I would pretty much expecting to have the same dentition as me, maybe not their wisdom teeth. Some 16-year-olds do, and it all depends. But we usually expect wisdom teeth to erupt around 18 to 21 years of age. But you never know. I'm 28, and mine have been coming through for the last 10 years, so everybody's are different. So at 16, they're pretty much at an adult dentition stage, and you can kind of start to treat them that way. Obviously, if you guys have looked up the eruption date chart, it all looks very kind of, whoa, like it's a load of numbers and quite intimidating. But as you start to practice and pick up, it's something that you don't even have to look at anymore. You just get to know it. Okay. One thing that's really important on there, you have the eruption dates, but you also have the enamel completion and calcification dates. And that's the kind of stuff that's important when you're looking at congenital abnormalities in teeth, and like I said, the tetracycline staining or hyperplasia, hypermineralization issues, or some syndromes can cause dental issues as well, and staining of the teeth. Excessive fluoride ingestion is another thing that can cause staining of the teeth, and can affect it the same sort of way that tetracycline staining does, with this kind of brown spots, but they're not so kind of chronological in a band. They're kind of speckled everywhere because they've affected the enamel formation continually throughout the patient's life, or early life even. So like what I really wanted to come back to is that don't get too bogged down with the amount of information on those. As you practice more and more, they'll just become second nature to you. So don't let that all the numbers there scare you. I would say it would be good to practice though, and just pick a random age out every and have a look and see if you can guess which teeth they have. Another good thing to look at is if you look at OPG radiographs, or orthopantogram radiographs of children on Google Images, they're quite interesting to look at as well, in terms of what age the children is and when the teeth are coming through, and you can kind of use that alongside the table, the eruption table, and kind of test yourself and see if you can work that stuff out. It's completely up to yourself. Obviously, you'll learn these things at undergraduate, but it would be very impressive if you kind of knew that stuff for an interview, or were able to talk through that stuff, because there's definitely a possibility that in an interview you could be asked here is an LPG radiograph, can you describe it to me? And if you've got the ability to talk a little bit about eruption, I think they would be very impressed with that. So just have a look over it, something that we all need to know. All right, cool. So I'm at the 20-minute mark. Seems like a good point to finish up. I just want to reinforce to you guys that if you are waiting to see Dr. Quinn, she can't make it tonight. So if you log on tomorrow at 7 p.m, she'll be here to talk through the medical PBL case and the rest of the study guide. Thank you guys. And if you need to email me with any questions, if you go on the website, my email address is there. Cool. Peace out.